Welcome, everybody. My name is Bertalan Tordai, and I would like to present the 9 months progress of our research on the effect of migration on healthcare. I'm a physician with 2 specialties, military medicine and occupational health medicine, and I'm also a first-year PhD student here in the Center for Translational Medicine. Me and my team have a vision, which is to assist migrants and immigrants in integrating successfully in the host society. And we would like to achieve it by identifying effective interventions for improving the health outcomes of migrants and immigrants. Right now we have 2 ongoing projects. The first will aim this topic on a broad scale, on a global level, with the help of a systematic review and meta-analysis. And the second one will have a shrunken scope, aiming only the EU with the Eurostat analysis. The first project of ours is on investigating the cardiovascular risks of immigrants in comparison with the host population. Immigration is a specific phenomenon. In 2022, more than 200 million immigrants arrived into the developed countries. Nowadays is much focus on asylum seekers and refugees. The first generation immigrants who have already settled down in the host societies pose a specific, unique challenge for the healthcare system. It is an already known fact that the prevalence of cardiovascular risk is currently declining in the host countries. In 25 years, avoidable mortality from cardiovascular disease is decreased by 57% across the EU, while these diseases still account for 11% of the total healthcare expenditure of the European Union. Meanwhile, it is also not known that the influx of immigrants impacts this declining trend, or how these risk factors vary among the first-generation immigrants. After we have dived into this topic, we chose selective preventive strategy, which aims a specific population and a specific risks or group of risks. From our point of view, the first generation already settled down immigrants and the main modifiable atherosclerotic cardiovascular risk factors, which are high blood pressure, obesity, diabetes, smoking, and high cholesterol, according to the European Society of Cardiology's guideline from 2021. Our aim is to identify these cardiovascular risk factors among immigrant versus host population. To meet our goal, we have formed the following clinical question. What are the levels of the main modifiable atherosclerotic cardiovascular risk factors among immigrants compared to the host population? We have formed PECO to answer this question, where the population will be the adults in a country with relevant immigration. We will compare this host population to the immigrant population, and we will look for the main modifiable atherosclerotic cardiovascular risk factors as outcomes. We hypothesize that the main modifiable atherosclerotic cardiovascular risk factors differ between the immigrants and the host population. If our hypothesis proves to be valid, we can directly transfer these results to the sake of the society by supporting the development of effective and efficient cardiovascular preventive strategies. We have done our search in November of 2024 with two domain search key. The first domain stands for the population, and the second one for the outcomes. And we got almost 20,000 hits. After going through the selection protocol, we have ended up having a little bit more than 600 eligible full texts. I think it's not a surprise that data extraction is still ongoing. We have done 2/3 of the extraction with the deadline of the end of June. The second project of ours is on investigating the prevalence of cardiovascular risk factors among immigrants in the European Union with the help of a Eurostat analysis. But what is Eurostat? It's the statistical office of the European Union, with over 2,000 statistical tables available, and they are publicly accessible and updated regularly by the help of service national statistical institutes and administrative sources. Eurostat provides the data as macro data, which allows us, which shows country-level data and allows us EU-wide or country-level analysis. But we would like to use the micro data, which shows individual level data and allows us a much more detailed analysis. Our research is based on 3 seemingly independent facts. First is that between 1995 and 2020, more than 11 million deaths from cardiovascular diseases in Europe were avoidable. The second is that by 2022, more than 5% of the total EU population consisted of non-EU born citizens, which amounts of 24 million people. And the third is that significant associations are between the cardiovascular risk factors and socioeconomic risk factors like age, gender, income, and education. These seemingly independent, 3 seemingly independent facts are connected by the prevalence of the cardiovascular risk factors, which are declining in the developed countries and increasing in the developing ones, where most of the immigrants come from. Additionally, the prevalence of these cardiovascular risk factors vary among immigrants with different origins also in the EU countries. So our aim is to analyze these cardiovascular risk factors among immigrants in comparison with the host country residents and EU averages and adjust them for socioeconomic factors. Okay, we have formed the following clinical question for this research. How do cardiovascular risk factors and major cardiovascular events among EU immigrants differ from those in the host population, considering the influence of education, income, age, and gender? We have formed, or we will use a PO framework to answer this question, but the population will be the people over age 15 in EU countries. We will compare them with the immigrants, and we will look forward the same cardiovascular risk factors as in the first project connecting the 2 researches. We hypothesized that the prevalence of the cardiovascular risk factors and major cardiovascular events is higher among immigrants than in the host population, with socioeconomic factors playing a significant role. If our hypothesis proves to be valid, we can directly transfer these results to support specific preventive measures, the most effective, simplest, and financially advantageous way possible. As a summary, we have 2 ongoing projects at the moment. The first will aim this topic on a global level, and the second one will aim only the EU. Both plan to be submitted in this year, the end of this year. I would like to end my presentation with a quotation from Oliver Napoleon Hill and a bit paraphrase it. A goal without a deadline is just a dream. Perseverance turns the deadline into the reality. Thank you for your attention.
Thank you very much. Questions from the audience?
Thank you for the excellent presentation. I'm not that familiar with the Eurostat part of your projects, and I was wondering whether the Eurostat database have exact data on the origin of the immigrants.
Yes. Microdata shows 2 separate information regarding the origins. Citizenship, which we might consider, but we won't use that one. And there is the place of birth. Of course, it's self-reportion, but we have to use that. Yeah.
Okay, thank you.
I would just add to this question. So if you have the data for the source countries, why is it not enough to only look at the source countries, basically? We know for a fact, at least I think we know for a fact, that socioeconomic status really drives cardiovascular risks. So if we look at the epidemiologies of these countries, we might just infer, the risk factors from those, from the people coming from those countries. Do you think there is an added value in looking at only those people who actually leave their countries and immigrate? So do you hypothesize that these cohorts of people have different risk factors than those who stay in their countries? Is it part of the hypothesis?
No. We have a lot of information. So we have three, let's say, course groups: the host, the origin, and the migrating population. We hypothesize that all three of them have different risk levels, but we will only, our study only aims the hosts and the immigrants. So we won't examine the staying ones.
Right.
But yes, we have data on them, so in the future we might take a look on this in this one too.
Okay.
Okay, I'm going to take advantage of the previous question and add the fact that during the previous progress report, several questions have risen regarding host data or the absence of it per se. I think you can provide more updates.
Yes. Originally we planned direct and indirect comparison, and yes, this will be the solution of the problem. We have host data from, we have only extracted the 2/3 of the articles, so till now we have only from around 50% of the articles. We only have host data from the half of the already extracted articles, but we can use these host data as a reference to the other, till now 50% of the articles. So we will be able to do indirect comparison. Originally we planned, or we also counted with national databases, but right now it seems we don't have to use these one.
Thank you.
Okay, then I would like to have one more question. How will you analyze the time spent in the host country?
We either do not have the length of stay. In 2/3 till now, in 2/3 we have somehow the length of stay, and we have mostly 5, 10, 15 years. So it could be a subgroup.
Some limited data will be available on that.
Yeah, it's a limitation.
Okay. Any more questions? If no, then thank you very much.